Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be discussing imaging of the liver. We'll begin with a general overview of liver imaging and then dive into each modality, starting with ultrasound, moving on to CT and then MRI. Along the way, I'll highlight key indications, strengths, limitations, and clinical pearls that guide our imaging decisions. Ultrasound is often the first imaging study performed when there is concern for liver disease, especially in the setting of abnormal liver function tests. It allows us to assess biliary structures and detect diffuse parenchymal changes such as steatosis or fibrosis. Common findings of a normal ultrasound examination should include homogeneous parenchymal echogenicity. You should have a smooth capsule with a regular contour, normal size of the liver lobes. Usually the right lobe measures 13 to 15 centimeters in the craniocaudal dimension when you put on your calipers, and the left lobe usually measures less than 7 centimeters in its width. And also you should have patent intrahepatic vasculature with no evidence of thrombosis. The gallbladder should have normal dilation and it should be free of stones, and also its wall thickness should be normal, usually less than 3 millimeters. I just threw in the gallbladder here because on normal liver ultrasonography we usually visualize the gallbladder. The common bile duct is also one of the things that you might see on ultrasonography of the liver and should measure less than 6 millimeters in its diameter. So this ultrasound of the liver is showing its homogeneous echogenicity, is showing some of the vasculature, and then the common bile duct is also highlighted here. The portal vein is highlighted here. The hepatic artery is pointed to by this arrow. The right kidney is usually in view just deep to the right lobe of the liver. Now, in patients at high risk for hepatocellular carcinoma, ultrasound is commonly used for screening due to its affordability and its safety profile. It's a non-invasive, repeatable tool, although its sensitivity can be limited, especially in obese patients or in those with cirrhotic livers. Doppler adds significant value by allowing us to evaluate blood flow. This is crucial for assessing hepatic inflow and outflow, transplant viability, or even the function of TIPS, transjugular intrahepatic portosystemic shunts. It helps us identify vascular complications like maybe portal vein thrombosis or hepatic artery stenosis. You can see all that when we turn on our Doppler, our color Doppler. So this image, the arrow is pointing to the bile ducts, and then the color Doppler is showing flow within the portal venous system. Now, while ultrasound is great for screening and vascular assessments, it struggles with deeper or isoechoic lesions. If the lesions are a little too deep, you will lose resolution. And if they are similar to the background liver too, you will not be able to assess them very well. And that's why any suspicious hepatic mass found on ultrasound should be further evaluated with CT or MRI for proper characterization. When it comes to CT, routine contrast enhanced study is typically performed in the portal venous phase. That's because the lesions might also be, again, iso dense to the liver parenchyma, so unless you introduce contrast, you may not see the lesion very well. Now, it's usually done in the portal venous phase. That's about 70 seconds after the contrast has been injected, and by this time the portal and the hepatic veins are opacified, and we can assess for the homogeneity of liver enhancement. Now, in the portal venous phase, diffuse changes like steatosis or cirrhosis are readily apparent. These diffuse changes are better assessed in the portal venous phase because, if you remember well, most of the liver's blood supply comes from the portal vein. Most metastases, which are usually hypovascular, will appear as hypoattenuating lesions in this phase. However, some lesions like breast cancer metastasis may be iso attenuating, and they may be a little less conspicuous on this face. The liver has dual supply, the portal vein and the hepatic artery. We already mentioned the liver takes majority of its blood supply from the portal vein. However, hypervascular lesions like hepatocellular carcinoma or neuroendocrine tumors that are supplied by the hepatic artery are best seen in the late arterial phase. That's around 45 seconds post-contrast injection. If a patient has a known hypervascular primary malignancy, including this phase can improve sensitivity for detecting metastasis. So this image shows an image in the late arterial phase. We can see that the abdominal aorta is very opacified. The hepatic artery is also very opacified, but the portal vein, the IVC, the hepatic veins are not opacified. You can also see the kidney is in the corticomedullary phase. That's kind of synonymous to the late arterial phase. For a thorough evaluation of suspected primary liver tumors, we use what we call the multi-phase CT, which includes a non-contrast phase, an arterial phase, a portal venous phase, and a delayed phase where the contrast would have washed out from the arterial and the portal venous system significantly. Each phase provides complementary information, helping us to differentiate between various lesion types and their enhancement patterns. So we can see in this image that the portal vein, the hepatic vein, the IVC, even the abdominal aorta don't appear that opacified. This was a delayed phase after the contrast had washed out of the vasculature significantly. MRI offers superior soft tissue contrast and avoids radiation exposure. It's particularly useful when CT findings are equivocal or when we need to characterize a lesion more precisely. Plus, dynamic post-contrast imaging can be repeated without additional radiation risk. So in this image, we are showing a T1 weighted image and a T2 weighted image just to show how the liver typically appears on these phases. So on T1, comparing the liver to the spleen, we can see that the liver is a little homogeneously hyper intense compared to the spleen, and on T2 the liver is homogeneously hypo intense compared to the spleen. MRI also includes specialized sequences, what we call in and out of phase images. This something called chemical shifts, and this helps detect intracellular lipid seen in steatosis and some tumors. Diffusion weighted imaging is also another powerful tool that is a functional MRI sequence, and it increases the sensitivity for small or otherwise subtle metastatic lesions. So these two images shows T1 in and out of phase images, and we mentioned that the in and out of phase images are good for intracellular fat. Also, because of the fat water interface between the organs and the mesentery, we have this dark line that seems to etch the borders of these organs. You can see this black line running around almost everything because there's basically a fat water interface at every organ border. So this interface is called the etching artifact or the Indian ink artifact in the in and out of phase images. Contrast agents come in two main types. We have the extracellular agents like gadavists, which behave similarly to CT contrast and are primarily excreted renally. And then we have the hepatobiliary agents such as eovists, and these are partially taken up by the hepatocytes and excreted via bile, providing functional information about the liver parenchyma. Eovists is especially helpful in evaluating focal nodular hyperplasia since it shows uptake in the hepatobiliary phase, unlike most malignant lesions. And it's also useful for metastatic workups, helping us identify and characterize liver lesions that might otherwise blend into the parenchyma. So to summarize, ultrasound is best for screening and vascular flow assessment. CT is the go-to for metastatic disease and general evaluation, especially in the portal venous phase. MRI, with its excellent contrast resolution and advanced sequences, is the most powerful tool for lesion characterization and functional imaging. Next, we'll talk about diffuse parenchymal liver diseases. I hope this video has been helpful. If it has, give it a like, share, comment, and subscribe if you have not subscribed yet. And I will see you in the next one.